So the apprehension for buying robotics or using was, number one, cost. It's a very expensive system, and the stress of having additional burden or yourself or the patient was obviously there. So we were not sure, but yes, we decided then finally that we'll go in for it. Then transition for the navigation system that we used to use. It was easy for us to get onto robotics because we were tuned to putting pins in the bones for computer navigated surgery earlier, which incidentally we started in 2007 in Jalandhar also. Learning curve, of course, in the beginning there was increased surgery time. We were worried if there is any going to be more infection because of that. Then stepping out of your comfort zone, that you're already used to a particular technique and you're going on and your time is fine, why change it? Then changing implants and of course the training of the staff. Results, whether it will actually work or not, even though there were enough literature and actual surgeons in the US that I visited who were using it, and we were sure that it's going to work. They were sure that it's going to work, but we had to see how Indian population will respond to this. And extra, finally we bought it. This is the team that did the first robotic surgery. Interesting hands-on training in US, with some very famous surgeons and developers of the robotic system at Pittsburgh University. And the learning curve, initial cases, there was a euphoria, you know of course, that we were excited about the whole robotics thing. Staff just needed one sawbone demo because they were used to doing computer navigated surgery. The first 5 cases, we were apprehensive, so we cross checked each case with conventional jigs. So take the femur cut, then put your open the medullary canal, which you would not open in navigation and in robotics. So you make a drill, check it conventionally. And we had the company rep standby on the floor. Hip registration, we had some issues with the side support, and now we have shifted to what we call the leg holder. So these are our results. We studied consecutive 147 patients from 19th April 2019, which is the day we started robotic surgery at NHS Jalandhar, and 15 January 2020. So 225 knees in 147 consecutive patients. We had robotic surgeries. 69 were unilateral knees and 78 were bilateral knees, which is a total of 156 patients knees. 46 to 84 years was the age span. 107 were females, 40 were males, 63 to 110 kgs. Implant used, most femurs were oxinium, all tibia were titanium, 95 were with patella round dome, 214 high flex inserts and 11 constraint liners were put. We'll come to why constraint liners, and 17 of them, because of probably weight or laxity or very bad knees, they had extenders in. Tourniquet was used in 59 bilaterals and 69 unilaterals, 23 atherosclerotic short or obese patients, and 15 no tourniquet by choice. So these were the patients where we did not use tourniquets because the world is progressing towards no tourniquet, no drain. So that is why we also chose to do it. Drains were used in all bilaterals and 53 unilateral knees. 63 unilaterals, there was spinal plus adductor canal block and the 7-point cocktail injection. 67 out of 78 led to bilateral knees. We used combined spinal epidural plus cocktail injection. 11 out of 78 bilateral patients had GA and 6 had unilaterals had GA. The average surgical time per knee was 60 minutes skin to skin. The first 25 patients average surgical time was 90 minutes, which is a big jump for us. And the next 60 patients average time was 55. Last 62 patients average time per knee was 47 minutes. All the patients were managed with oral and IV analgesia. Checklist was maintained for all patients. This is our medication protocol that we use for all TKRs. Recovery time. So we give them pre-operatively one tablet of Nicoxia with gabapentin, and in the pre-operative room they get the adductor canal and IPAC if at all is there. Injection MSET 4 mg IV is given in the pre-op itself. Intraoperative cocktail has got 20 cc of saline, 49 ml of ropivacaine, 0.8 ml of clonidine, 0.5 epinephrine, Lactagard, Trenexa at closure, and amikacin at closure. In the recovery, we give them injection MCET, and then on day one, it is 3 times a day. Injection PCM 1 gram IV stat is given in the recovery, and then twice a day. Injection Dynapar, which is aqueous diclofenac, intramuscular after 2 hours and before shifting to the room. So we've toned this down already, and we've come the use of IVP MSAT has been reduced to minimal, and NALFI we've not used, I think, in the last 100 patients. Tranexa also we've cut down, but tablet gabapentin has continued at discharge. Just a simple antibiotic, paracetamol, one gabapentin, and nicoxia, and Stemetil with ice packs and exercises. Now, we had 218 knees, which were an average of 13.2 degrees varus, 7 knees with an average of 10 degrees valgus. Post-op mechanical access planned target achieved less than 1 degree variation in 96.8 patients and less than 3 degree variation in 7 out of the 225. Error recognized as tibial varus in 5 of them, recognized in femoral valgus in 2 of them, and hip this error minded is not actually an error, but as compared to a conventional, where you can't even measure this, at least we are able to measure what's happening in a routine conventional surgery. No matter how careful you are, eyeballing cannot match robotic surgery. There were hip registration issues in the beginning, so the femoral valgus was actually a result of that. There was a post-op gap mismatch. 4 patients landed in residual flexion. 3 of them stretched out gradually, even though on-table robotic showed full correction. And 1 surprisingly went into further flexion and needed to be released at 4 months from date of surgery. No pin was knocked down or moved even in a single case. Trackers were changed in 3 patients during surgery because of blood splatter, or because if they are ETO'd, sometimes they when you reuse a tracker and there is the foil of the tracker gets bubbled up. Besides the first 5 patients, 2 were rechecked with conventional jigs. Only 2 in the entire 225. 10 knee pins were put, 1 in and 1 out of the wound. So the last 10 cases, we were doing 1 pin in, 1 out on the tibial side. The rest all were away from the incision. Incisions have become way smaller after 20 cases. 135 patients were mobilized 3 hours after surgery. The rest 90 walked within the first 24 hours. 117 patients were left the walking aids, all sorts of walking aids by the 10th day. All generally leave the walking aids by the 20th day. Wound issues. So there were 1 case had cellulitis at the tibial pin site. 2 knees had superficial wound infection at 7 days, needing IV antibiotics for 5 days. And 3 knees had superficial wound infection at 7 days, not exceeding the IV antibiotics, not needing the IV antibiotics. No clunks. 1 patient had a bilateral patella sublation, turned out to be an asymmetric polyneuropathy case. 1 83-year-old had a quadriceps rupture 3 weeks, which were 3 weeks after surgery, which was repaired, and he was immobilized for 4 weeks. The patient is doing very well, and now we've stopped putting the pins through the quadriceps muscle in the femur side, and we are putting it only on the just near the just on the lateral contact. 1 78-year-old had a spontaneous hemarthrosis 3 weeks post-op while driving a scooty, which was evacuated, and another 2 weeks later he subsequently bled in the calf, which was evacuated. No blood dyscrasias were detected. All is well with the patient now. No DVT was detected in any of our patients. All patients more than 65 years of age or 70 kgs weight got a post-op DVT prophylaxis for 3 weeks. No stress fractures were seen, and the average drain per knee per stay was 135 ml. Pain from the quadriceps pin site reduced after the removal technique was changed. So we started putting in the sleeve before removing the pin. So, the pain became almost nil. Unbelievably detailed planning is the distinct advantage of robotic knee replacement surgery. We can see today what the eye cannot see by use of artificial intelligence algorithms. Extremely reliable sculpting of the bone in ways not possible with conventional tools. Kinematic balancing, which is minimal release of ligaments, less pain, much faster functional recovery, reproducible results with excellent outcome, and no opening of the bone, which leads to minimal bone loss. Thank you for a very patient listening. This is just to show how the knee moves. Zoom it. Okay, so all those who are watching on YouTube link, we are thankful to them for their participation. And now we will just show you a video, a quick video. We are not showing you the live surgery. So we are taking you to, we've made a video in the past and we are going to take you into the operation theater of NHS hospital to show you a video of the robotic knee replacement surgery. उसके बाद में ये काम जो है